Okay, welcome. We are now live. My name is Dr. Fahim Shakur. I'm a GP. Welcome to another live episode of Med Talks on both Facebook and YouTube. I'm really pleased that we've got two great consultants with me today to talk all about sexual health and obviously to do with good sexual health this evening. I first want to introduce Dr. Tina Dwivedi, who is a consultant in contraception and reproductive health at Blackpool Teaching Hospitals NHS Trust, and who started first in obstetrics and gynecology and then moved into contraception and sexual health. She's also a medical educator, co-author of a revision book of her speciality, mother of two, and enjoys traveling and creative writing. I've not quite finished yet. She has also done charity camps in Nepal and has done webinars during the pandemic for women in Nepal and India. So a really warm welcome to you, Tina, this evening. Excellent. And also alongside, we also have Dr. Chitra Babu, who is a sexual health and HIV consultant in an inner city hospital in the northwest of England. Her interest obviously is HIV and how it affects in neurology as well as conception. And I really hope that we have a very informative evening with both of you tonight. Thank you. Excellent. May I start with you, Chitra, if that's okay? For the audience tonight, just set the scene really. What is sexual health and what are sexual health clinics?
So sexual health clinics, we're very fortunate to be in the UK where there's good sexual health services. And a typical sexual health clinic would be something that provides integrated sexual health. So that includes screening and treatment of sexually transmitted infections, but also catering to contraception, other things like skin problems that affect the genital area, sexual dysfunctional, and to some extent counseling. So it's really a holistic approach to looking after one's sexual health. Sexual health clinics in the UK are open door. You don't need a referral from your GP. You can self-refer yourself. And moreover, lately, sexual health services, they are quite advanced, as in you can book your appointments online. You're provided with a confidential service. Patients who don't have any symptoms can simply request for a testing kit that will be posted to you. So it's a service which is very, very easily accessible. It's confidential and also it's free. So, there's no reason that if one has got any problem to do with their sexual health, why they should really sit on it. It's really easy to go into a sexual health clinic. The easiest way to find one near you would be to really Google it or to go on the NHS website, put your postcode, and that will come up with the sexual health clinic that is really near you.
Excellent. Thank you. And Tina, is there anything you want to add? Obviously, your specialty is contraception as well. And there's this term of cash clinics as well. Can you tell the audience a little bit about what a cash clinic is and maybe a bit about your role as to what you exactly do on a day-to-day basis as well?
Yeah. So cash clinics are contraception and sexual health clinics. So they're pretty much what Chitra has been describing there. So again, patients, whether they're there for sexual infections point of view, or whether they're there from a contraceptive point of view, or there to have opportunistic cervical screening, we can see them for a whole range of issues. So they can attend the contraception and sexual health clinics. Like Chitra was saying, we do have open access clinics as well as booked appointments, and patients can self-refer. And I think it's important because a lot of people don't realise that they can self-refer. They feel that maybe it requires a GP referral, and that's not true. So certainly they can self-refer. My role as a contraceptive consultant, although I do dabble in a bit of genitourinary medicine, but as a contraceptive consultant, I deal with all of the complex contraception issues. So anyone who has had failed attempts at coil fittings, or if there are, if they can't feel their threads. Often in my service, I'm also offering a scan facility where I will scan these patients myself and do procedures for them. We also deal with deep implant procedures in our clinic. So there's a variety of things that we do. We cover the areas in East and Central Lancashire and also the Blackpool patch and the Lancaster area. So we have a wide geographic area that we cover. Certainly for patients who are in the East Lancashire area, they can refer to our clinics using our single booking line number, which is an 0300 1234 154 number. And those who live in Blackburn with Darwin can ring on 01254 283 3888. So that's the way to get in touch with the cash clinics in your area.
Excellent, great. I think we've got a good foundation for tonight's evening. Chitra, coming back to you in terms of your specialty, you deal a lot with HIV, and I think we should give a good section and amount of time to that. HIV is something that's well within the nation's consciousness. It's come through the media. I think it's fair to say in the past there was a stigma associated, and then it's changed as times have changed as well. Can you tell me about what you've noticed whilst you've been a consultant as to the way HIV has been portrayed and how it's seen now?
Yeah, so it's changed significantly and massively. I think in short, what I'd like to say is HIV is a treatable condition. It's a chronic condition, which if diagnosed at the right time, started treatment, patients with HIV will have a near normal life expectancy. And they can go on to lead a healthy lifestyle, go on to have successful careers, live all the dreams that they ever dreamt of, but also go on to have children. So the management of HIV has changed a lot. Patients with HIV in the UK get some of the best care. The stigma is reducing, but it still stays to some extent, which, as medical professionals, but also the community, still continues. It's something that we continue to work at. One of the very significant developments that happened in HIV was the U is equal to you campaign. And that basically means that undetectable is equal to untransmissible. And in common language, what that means is that somebody with HIV who is on treatment and they're on successful treatment where their virus is controlled with the HIV drugs, they cannot pass the virus to anybody. And that's a very, very strong statement. And that's, kind of speaks volumes for how HIV care has changed. Saying all that, we still continue to do a lot of work, but that's maybe one of the messages I would really like to kind of deliver today. But also, when we talk about successful HIV management, that really starts with diagnosing HIV. So HIV people can have, but they can have no symptoms for a very, very long time. So unless you have a test and they find out that they've got HIV, that cannot be treated. Also, when patients have HIV, they don't know they have it, they unknowingly pass the virus to other people. So not only for the individual, but also from a public health point of view, diagnosing HIV is important. Having an HIV test is very simple. It's a blood test. People still have sometimes concerns and a bit of fear having the HIV test, but again, the thing to remember is that it is a treatable condition for which we have very, very excellent treatment.
Excellent. Tina, obviously you deal with contraception, and what role does contraception have in terms of transmission or preventing transmission of HIV? Obviously, can you just tell the audience a little bit about some of the benefits of contraception?
So obviously the benefits of contraception are reducing unintended pregnancies as a result of sexual intercourse. And I think that's important for all women. There are methods which are long-acting as well as the short-acting methods. So the ones that are taken on a daily basis, and then you have the ones which are the long-acting ones, which you would take less frequently than once a month. These are the superior methods of contraception, and certainly for someone who's not looking to get pregnant in the very near future, I would be encouraging them to use a long-acting method of contraception. They are reversible methods, and I think it is important to realize that actually, whatever contraception method you're using, as long as you're using that method, it will stop you from getting a pregnancy, which you're not intending, but it wouldn't necessarily protect you from sexually transmitted infections. So for those, using condoms, which are barrier methods, is very advisable to do. So in terms of what we offer in our clinics, we would offer a whole variety of the methods that are available. And women are given a choice. They've given all the relevant information. They're explained about how that method acts, how it would affect their bleeding patterns, which is quite important to a lot of women. They need to know how it would affect their bleeding patterns. And that goes for the patients who have HIV as well. Quite often we put them into categories of the ones who have heavy periods. So they may decide that actually they want a long-acting method, but they don't want to use something like the copper coil because that can make your periods heavier and possibly longer and possibly more painful. So they may opt to choose something like the Mirena coil, which has hormone in it. And we know that after a few months of funny bleeding, that can eventually settle bleeding to the point where they're barely bleeding at all. That tends to be quite a popular one that I've noticed whenever the patients with HIV are coming through. They like to have something solid and reliable and something where they're not having to worry about the bleeding. So I do find that the Mirena coil is quite popular with those patients.
Great. I will come. Yeah, go ahead, Chitra.
So just kind of really reiterating what Tina was saying, when you're talking about transmission of HIV from a positive to a negative person, condoms are by far the best. And even though, HIV is a serious virus, when it comes to transmission, if condoms are used correctly, they are very, very effective. It's not very transmissible. So condoms, if used correctly, will prevent transmission of HIV. When you're talking about contraception for the need of not conceiving or, for family planning reasons, then obviously there's a whole range. With a woman who has HIV and who wants to be on contraception, one of the things we have to be very aware of is that whatever mode of transmission she chooses, that does not interfere with her antiretroviral medication, because sometimes there can be quite, there can be significant interactions between the contraception and the HIV drugs. So that's something we have to keep in mind. And as Tina said, the Mirena coil is a good option. The other one is Dispel. But again, going back, contraception for the reason to prevent transmission, condoms would be the method.
Yeah, Chitra, I just want to move on and keep on the topic of HIV with you. We know that certain communities are affected more disproportionately than others. And obviously the BAME community is one of them. Can you tell the audience a little bit about the more disadvantaged communities and how we can perhaps reach out to them? Because there's a lot of people with HIV undetected and unknown, and we can't help them unless we know about it, right?
I think firstly, it all starts with spreading the message and really understanding that, yes, HIV is a serious condition, but, we are not in kind of 30 years ago when HIV first came about and we had no treatment for it. And, it was almost looked at as a death sentence. Times have changed, in fact, quite dramatically. We have some of the best treatments for HIV. So understanding that yes, if somebody's got HIV, that needs to be addressed, and that's going to start with diagnosing somebody with HIV. So taking that fear and stigma away. Secondly, again, looking at sexual health clinics, one can get an HIV test with their GP at the GP surgery, but it's something they feel concerned about just walking into a sexual health clinic or, making an appointment online by phone, self-referring for an HIV test. For some people, it's a big step, but, in the grand scale of things, for their health is probably the one most important thing that person can do. So not looking at sexual health clinics as this scary place, or, that it's for, it's not a nice place to be. As I explained earlier on, at sexual health clinics, we look after sexual health in a holistic way. STIs are a small part of it. We look after contraception. We do look after patients with HIV. We look after skin problems, sexual dysfunction. So there's a whole variety of reasons why people come, and the age group is wide. We look after very elderly patients too. So starting off by having an HIV test, as I mentioned earlier, these days most sexual health services will offer online, services, wherein if somebody doesn't have symptoms or they just want what we call a sexual health MOT or a peace of mind check, you can literally just order a self-testing kit that can be posted to their address. You can do a full sexual health screen that includes testing for things like gonorrhea and chlamydia, which for a man would be a urine sample. For a woman, it would be, a swab that she takes herself, and a blood test, which is a finger prick test, which will test for infections for blood-borne viruses like HIV, hepatitis if needed, and infections like syphilis. So all that a person can do in the comfort of their house without having to go through, what we call a sexual history in clinics, where you have to answer some questions. Again, important information. But if one feels that they just need a, sexual health screen just for peace of mind, this is probably the easiest way, where you can request all of this online and do all of these tests. You send them back to clinic, and within 2 or 3 weeks, you have your result. So I think when we talk about HIV, especially among our community, a lot of stigma remains, but it's for us to make people understand that this is a treatable condition. Lot of times it's compared to something like diabetes, very different condition. But when we talk about the chronic nature of it, the management of it with drugs, they're quite similar. So it is definitely a condition that at present we can't cure, but we can treat very successfully for people to have long, healthy lives.
That's great. Yeah. Tina, coming to you about contraception, that's really important topic and lends itself to STI, which I want to focus on for a large portion of tonight's evening as well. You did mention some things to do with contraception, and I guess we've had a lot of questions before the show, people asking how are remote consultations happening in terms of giving out contraception to the public, because a lot of people are now accessing you via telephone. Can you tell us how that's been for you as someone working out there?
Yes, so I think we always used telephone consultations to some degree. However, in the current COVID situation, it has been that we've had to rely a lot more on telephone consultations. In our service as such, because it is an essential service, we are doing the important job of reducing unintended pregnancy. So we have been identified as an essential service, which has needed to keep running. So I have been seeing patients throughout the COVID pandemic, whether that be patients who are in pain or having any problems with their contraception. However, with the telephone calls, yes, we have been doing a lot of our consultations over the phone, a lot of counselling over the phone. And what we've been doing is a lot of provision of the progestogen-only pill. So this is, in other words, called a mini pill. It's desogestrel. So this pill is relatively safe in most conditions. Now, the issue when you compare it to the combined oral contraceptive pill is that with the combined pill, you do need to have had at least a documented weight and blood pressure, a calculated BMI in the prior at least 12 months or so. And due to the pandemic, that wasn't always possible. So we have relied a lot on POP, the progestogen-only pill provision. So the patients have been able to ring our service and have a consultation with a nurse over the phone, where they've been able to discuss their contraception needs, and we've been able to then either keep a supply of progestogen-only pills, which they can come and collect from our reception area, or they can send a designated person to come and collect from our reception area. Sometimes we have been posting out the progestogen-only pill if patients are unable to come and collect from our service. And also we've made quite an effective use of the NHS volunteers as well. It's been a fantastic service, and they have helped us out in delivering medication out to patients. So that's been one of the main things that we've been relying on, is the provision of the progestogen-only pill. Now, certainly during the pandemic, the other ethos we are going with is the fitting of long-acting reversible contraception. The provision of that is more important at the moment than removals. So whilst I may have done a few implant removals and coil removals during this time, it is really important that we are focusing on the fitting as well. I think the telephone consults are great in the sense that you can actually see whether the patient actually is needed to come at that time, or whether it's the right time for them to attend, or whether they can be given a different method as a bridging method in the meantime before they come and have a procedure done. I think one of the downsides of the telephone consultations is there is a chance of missing safeguarding issues. So we do have certain ways that we do try and get patients to clarify whether they're on their own in the room, ask whether they're on speaker, but there is always a risk of missing things. And that's why, especially in young patients, we do like to see them face to face.
Excellent, very thorough answer. Thank you, Tina. Chitra, I want to hang on something Tina just said there, and that was obviously safeguarding. And sometimes sexual health clinics have sexual assault centers maybe attached or nearby. Can you tell us a little bit about where that can be and how that works?
So Sarc clinics, or Sarc Centers, which is the sexual assault referral centers, they are throughout the country. In Northwest, one of them I can think of it is the one in St. Mary's in central Manchester, and then there will be other throughout the Northwest region. And they're often attached to a sexual health clinic, so it's not uncommon while working in sexual health to get referrals from the Sarc clinic or the sexual assault referral clinic. And Sarc clinics, patients have to self-refer, they have to refer themselves. And even when we talk about historical sexual assaults which have happened in the past, but patients who have not accessed help or who would like some help, they have anonymous phone lines that you can ring, one can ring for to get some help. But in terms of the initial, when a sexual assault has just happened, it's a sexual assault referral center where the initial forensic examination will happen, and then the patient is often referred to the sexual health clinic for follow-up or for screening, and if they need any treatment and other things like post-exposure prophylaxis for HIV if indicated, and also vaccination. So these clinics, like I said, they are spread across the country. A patient can refer themselves, and they have phone lines that one can access for help as well.
Excellent. We want to move on to STIs as well, sexually transmitted infections, Chitra, as that is your speciality. Can you ease us into this, what possibly might be a bit of a graphic section of the evening, and actually tell us a little bit about what is normal, that is a normal discharge perhaps that someone may come across, and just what's normal, and then we'll go into what's perhaps abnormal.
So I think a woman is probably the best judge of what a normal discharge is. So if you talk about a normal discharge, it's different for different women. You know, some women don't have any discharge, whereas other women will get some discharge, which is normal for them. And a patient or a woman herself is the best judge of, she will know when things are not normal, if a discharge is abnormal. But talking from more a kind of medical point of view, you know, a normal discharge is something, you know, that is usually clear, something that is not associated with other symptoms such as, you know, any soreness or itching or any unusual odor or smell. And that's what's kind of known as a normal discharge. But like I said, it varies from woman to woman. And even in the same woman, depending on the time of the cycle she's in, the discharge can vary. A discharge tends to be abnormal if it's causing the lady some symptoms such as soreness or itching, or if she notices an unusual smell or odor, and also if she notices some abnormal bleeding in it. And that's when I would say to access some help. One could go to their GP, or, you know, even easier would be to access you know, GU service, a sexual health service. An abnormal discharge is not always due to a sexually transmitted infection or STI. The most common of this causes of discharge in a woman are things like thrush, bacterial vaginosis, neither of which is a sexually transmitted infection. But unless they get looked at, be examined, and have some simple tests, you know, they're not going to know.
Excellent. And Tina, obviously, contraception is going to really overlap a lot with sexually transmitted infections. Tell us the role of contraception and in obviously trying to prevent sexually transmitted infections in further detail for the audience.
Yeah, so this is sort of piggybacking on what Chitra was mentioning before, and what I'd also said earlier on in the show, that actually, you know, all the contraceptive methods are great at preventing a pregnancy, but in terms of preventing sexually transmitted infections, condoms, if they're used along with those methods of contraception, are the methods to stop that happening. Condoms get a bit of a bad rap. There are many couples that use condoms as their only method of contraception and have done so successfully. If they're used well, they're great. However, they're not used perfectly most of the time. And so their failure rate does increase. It tends to be that they're probably classed as just over 80% effective, with typical use. However, they are fantastic at reducing the risks of sexually transmitted infections. So if there is that worry, I would always advise women to use those alongside their main method of contraception. We know that with certain contraceptives, there is a change in women's discharge as well. You know, some of the ways that the hormonal contraceptive methods act, amongst other ways, is to also thicken the discharge and the cervical mucus that is at the cervix. So that can happen as well. So women do notice a change when they start hormonal contraception in their discharge as well. And it's just to be aware of that can sometimes cause that as well.
Okay, great, Tina. And I'm conscious that it's Trans Awareness Week as well this week, and we've talked a lot about women, but I think it's only right that we mention all kinds of people come, isn't it, to the clinics. Do you want to talk a little bit about, Tina, as to how we're breaking down stereotypes and things as to who actually comes to access your services?
Absolutely. I think our services are accessed by many people. So as Chitra was mentioning before, you know, we get males and females obviously attending our GU and the contraceptive clinics as well, but also trans people. You know, we're very happy to be able to say that we do provide care to trans people as well. And I think sometimes they can be they can be the population that can get overlooked, and I think, you know, historically they maybe didn't get a fair deal in these services, but as we're becoming more aware and people are becoming more educated, and we are providing training to staff about how to deal with issues that crop up, it is important. And certain things, like if people are transitioning from female to male, but however, you know, aren't quite there in that process, it's about remembering about their contraception as well, and just making sure that they're looked after. Also remembering things like cervical screening as well.
Hold that thought about the cervical screening. We're going to kind of come back to that. That's really important. Before I do, let's go back to Chitra. Chitra, we talked about what's normal. So now let's talk about what's abnormal. And can you tell us what is abnormal? And, you know, let's actually try and break down the different sexually transmitted infections with, say, the common ones first, really.
Mm-hmm. So just before that, Fahim, I'm just going to go back to the condom use. One of the important points we always like to make is, you know, when we talk about condoms preventing STIs, if used well, they're very good. But what one must always remember is that when we talk about condom use, they have to be used from start to finish. So often people think that STIs or sexually transmitted infections are only transmitted through ejaculation, but that's not correct. A lot of the STIs, they get transmitted or passed on by just skin-to-skin contact. So it's very important that when one is using condoms for prevention of STIs, they have to be used from start to finish. Okay.
Great. And moving on to what's abnormal then?
Yes. So abnormal, I'll start with a discharge because you had talked about that. So we talked about, you know, we're talking about abnormal discharge, one that is associated with other symptoms as itching or soreness, or if one notices abnormal bleeding. The commonest causes of discharge are thrush and bacterial vaginosis, neither of them which is a sexually transmitted infection. Thrush is a yeast that lives on the body surface, and it can cause symptoms due to overgrowth or entering through broken skin in both men and women. In women, typically they get a thick discharge, which causes a significant amount of soreness and itching. And it's something which is easily treatable. You know, there are treatment which can be topical or something that can be used down below, things like pessaries or creams, or it can be treated with tablets. And we also often talk about lifestyle factors, you know, ways one can prevent getting recurrent thrush is, you know, simple things like keeping things dry down below, also wearing loose-fitting cotton underwear, avoiding very tight or synthetic underwear, and you know, simple measures like that can reduce the recurrence of thrush. Bacterial vaginosis is also a common cause of discharge in women. It typically causes a discharge, quite kind of liquidy yellow discharge, which can be associated with an unusual odor, which can usually get worse after sex. And bacterial vaginosis, again, is not an STI. It is just an imbalance of the normal bacteria women have down below. And again, this can be set right or treated with antibiotics, but there are simple things women can do to try and prevent it happening over and over again. And what we talk about is avoiding very strong scented perfumed products down below, avoiding overwashing, you know, simple things like that can keep the normal balance down below. So those are some common causes of discharge. And then when we talk about, you talked about what are the common sexually transmitted infections. So one of the commonest STIs which we see in the UK is chlamydia. We often call it the fashionable STI because you know, it's something which is common, and it's common because majority of the patients will not have any symptoms at all. So, most women and men with chlamydia will not get any symptoms at all. And that's why it's common, because unknowingly, then people pass it from one person to another. And the rates of chlamydia, especially in the young population, are high. So again, this goes back to the importance of screening, asymptomatic screening. So if you have a new partner, it's not unusual for couples to come to our clinic, start a relationship. They just want to have a full sexual health screen before they embark on a long-term relationship. So getting tested, even if asymptomatic, is important to diagnose things like chlamydia. Treatment is simple. Why it's important to treat? Because in a very, very, very small proportion of women, if you don't treat chlamydia, it can lead to complications, which can be severe. It's a small proportion, but the complications are severe. So the importance of screening, detection, and prompt treatment. Another cause of discharge is gonorrhea. So gonorrhea is not as common as chlamydia, but a very historical condition, and that's where kind of the term clap clinic comes from. So gonorrhea, again, can cause, unlike chlamydia, it's usually symptomatic, especially in men, where they can get a lot of discharge, and that's kind of associated with a lot of burning while passing urine. And again, half the proportion of women who get gonorrhea will have no symptoms at all. So again, the importance of screening, testing, and treatment. So those are some common causes of discharge. There are some other STIs like Trichomonas vaginalis, which can also produce a discharge. But these are all the things that one will be screened for in clinic.
Excellent. I'll come back to you a bit later on for perhaps some more. Tina, we mentioned cervical cancer, and I think that's important to focus in on that now. Could you tell us a little bit about how that, in terms of sexual health services, how you get involved with screening? And also, I think what's important at this stage is also tell people how you make them comfortable, because obviously you're a sexual health consultant, and part of your consultation, you're asking a lot of personal questions by definition, people about their sex life, sexual partners and so on. And so what are the techniques that you use to try and put people at ease?
Okay, so yeah, it can be quite embarrassing for people to be attending our service. And I think, as we were saying before, that there can be a bit of stigma attached to attending sexual health services. And we are trying to work on that and work with community so that we can tackle that. Certainly from our point of view, we do try and make people feel as comfortable as possible when they attend our services. And part of that is not only our manner and the training that we deliver to our reception staff. So right from the beginning of when someone accesses our service, right through till when they are seen by us, we do reiterate to them the confidentiality and the limits of confidentiality as well when they're attending our service. We do try and put them at ease. We do say that, we will be asking them about their general health, and some of those questions will include personal questions as well. And that does tend to kind of prepare them for the nature of the questions that we're due to ask. I think by attending a sexual health service, they are aware that we will be asking questions that are sexually related. I think the main thing is, as a health professional, when we're addressing these issues, is to make sure that we are not acting embarrassed about asking these questions. Because if we're not embarrassed, they will see that as it's quite normal to talk about these things. Whereas if we're showing hesitancy with that and embarrassment, then they may not be as open as they wish to be. Because of that, we are aware that some people may attend our clinics with their presenting problem as something actually totally different to what is really bothering them. And that's why it's really important that we act in a very non-judgmental way, and that we're we have a good manner with our patients. In terms of cervical screening in the contraceptive services, we do opportunistic cervical screening. So we do have some clinics dealing with cervical screening, and if the woman is due a smear test and we're about to do a procedure, then we would do that for her, just so that we're not delaying her getting cytology done, because usually once they've had a procedure where we've been messing around with the cervix, such as a coil fitting, it does mean a delay of 3 months before they can have cervical cytology. So usually we do try and do that in the same sitting. So it is important. We do reiterate to women, just because we know that the uptake of cervical screening isn't great, and especially in people of the BAME community, we do know that it's even worse. So it is, we do try and make a point of stressing the need for going for smears, and get that across to patients whenever we see them in our clinic.
That's great. Thank you so much, Tina. Chitra, obviously, you mentioned something interesting at the beginning of the show, and that was the different reasons people come to the sexual health clinics, and it can be sometimes you examine the groin area and things. Obviously, in terms of sexually transmitted infections, you've talked a bit about chlamydia, but there's also genital type of infections that are manifest on the skin. Could you speak a little bit about skin manifestations and lumps and perhaps around there that might present to you?
So talking about affecting skin down below, when we talk about, sorry, Fahim, did you mean?
Exactly. So, when you get like a itchy genital or a lump or growth around the genital area.
Yeah. So we're talking mainly about infections causing lumps, bumps, or sores or ulcers down below. So we're talking things like genital warts. It's the commonest STI. When we talk about how many people carry the virus that causes genital warts, it's the commonest STI in the UK. And warts are caused by virus, which is passed by skin-to-skin contact. So again, going to the point of wearing only condoms during ejaculation, not enough, because things like warts will get transmitted by skin-to-skin contact. Warts are actually harmless. They are benign lumps that are caused by a virus, the HPV human papilloma virus, related to the family of viruses which cause more serious things like cervical cancer, but not the same viruses. The viruses of HPV that cause genital warts are benign or innocent. The only reason we treat genital warts is for cosmetic reasons and for them not to get worse. So we've got several treatments, topical treatments. Sometimes we apply cryotherapy to them. And the main purpose of the treatment is solely to take the warts or destroy the warts away. They can come back and then we treat them again, but most people will eventually just get rid of the virus themselves. Another common cause of lumps down below, or more like sores or blisters down below, is the cold sore virus or the herpes virus, which is quite common. And again, it's one of those conditions which, again, unfortunately carries a little bit of stigma. But it's something that is very, very common. A significant proportion of the people in their sexually active years will carry the virus, but only a very small proportion of the people will actually go on to get symptoms with it. So when I diagnose a patient with a first attack of the cold sore virus or genital herpes, I try and explain to them that it's very difficult to tell them where they got it from, who they got it from, purely because it's such a common virus. And most often people get it from somebody who perhaps didn't even know they were carrying the virus. Again, the treatment is symptomatic. Our main purpose is to try and take the symptoms away. The treatment doesn't take the virus away, but eventually over time, people do develop some kind of immunity and, they get outbreaks, but the number of outbreaks then decrease over the following years. So these are two of the common conditions which cause, lumps or sores down below. Another condition which we've seen quite rising, especially in the Northwest, is syphilis. It's a condition which can completely remain asymptomatic. People don't get any symptoms, but typically the symptoms include sores down below, which are completely painless. Sometimes they can develop a very florid rash throughout their body, typically on their hands or palms, but palms and soles of their feet. And again, a simple blood test can diagnose this condition. So these are some common conditions which can cause, rashes, sores, lumps. HIV sometimes, especially in its very, very early stage, when somebody has just contracted the virus, some people can also develop a rash throughout their body. So again, accessing help and going to the right surveys to get these tests is important.
Excellent. Tina, I've been flashing up some questions on the screen to give you some chance. Maybe we can go through some questions. So in no particular order, I mean, we've got one here that links in well with what you were saying about cervical cancer. And what's the situation with giving males HPV vaccine? Is one of the viewers is asking. Tina, are you okay to take that one?
I think I might give that one to.
Okay.
I know with the girls that they are giving the vaccines in school, but they aren't giving any of the. They're not doing catch up with the males, from what I understand. Is that correct, Chitra?
Yes, you are right. So it's something I think the community in sexual health fought very hard for. When the vaccination started initially in girls, we really wanted boys to get vaccinated as well. To start off with, they were kind of trials or pilots running where we were giving the HPV vaccine to men who had sex with men, because there's it's considered high risk group for the virus. But more recently, vaccination has been approved in boys. And again, as far as I'm concerned, there's no catch up, but now boys are being vaccinated.
Excellent. Whilst I've got you there, Chitra, how about another question? So we've got one coming up, and it links into what you asked. We're talking about lumps and bumps. How has COVID impacted on the nature of such presentations in reference to lumps, bumps, and affected areas? I guess it's asking about with, the lack of face-to-face contact and maybe trying to adjudicate or judge this over the telephone, perhaps is what it's alluding to there.
Yeah. So I think one thing, at least I can speak for where I work, and probably for most sexual health services, is that at no point, even at the height of lockdown, we closed our doors. So in kind of April, May, when we were at the height of lockdown, the majority of my specialty was redeployed to the medical wards, but we did keep our sexual health clinic running. And how we ran services, and we're still to some extent running, is that we almost triage with a virtual consultation. So we have a phone consultation. And again, some of the things you have to keep in mind is what Tina said, that you have to make sure that the patient's on their own, you've got the right person, there are no other issues. And we've got ways to kind of try and gauge that. Is there a safeguarding issue? But once all that's done, we have a very comprehensive virtual assessment where we go through all the questions. And then if a patient needs to be seen, and that's where you're talking about your acute symptoms, if somebody's got ulcers, somebody's got pelvic pain, testicular pain, we will see them. So what we have tried very hard is that, these things not to get missed. And to make sure that the urgent things are being addressed. For non-urgent things, we've got a variety of services. We've got things like click and collect, home testing kits. So we're trying to do our best. Now, saying that, I do think that during the extreme lockdown, some things have been missed. And I think this is more to do with the concern on the patient's part, to not to access services, or to kind of wait until things will be better, or not to come to the hospital. So, we have seen some, for example, I can remember some cases of syphilis, which probably should have been diagnosed a few weeks earlier than they presented. But, as I said before, I'd like to say that at no point the clinics were closed. It's just a different way we're working now, that we first have a virtual consultation. and then see the people who need to be seen, and the other people we try and do, with other services online, click and collect. We also have some conditions which we will see no matter what, and this is where you're talking about young persons, victims of sexual assault, if somebody needs emergency contraception, or if somebody needs post-exposure prophylaxis for HIV. So these people, we will see them regardless of what's going on.
Great, thanks. Tina, obviously the contraception expert. I think there's one thing we've not mentioned, and that's contraception is free, is it not? If you want to mention a little bit about that and where people can get there, because everyone loves something free, so I think we should plug that.
So yeah, coming to the cash clinics or the contraception and sexual health clinics, we do give contraception for free in these clinics. Now, emergency contraception is the morning after pill, as people know it. That is something that people can also access from pharmacies as well. But not every pharmacy will provide that free. Most of them do, but not everyone will. So it's worth for people to look up online before they go to a pharmacy if they're expecting free emergency contraception. In our services, we would provide that free, but it's just if they're going to pharmacies, it's to be aware of that. So emergency contraception, the morning after pill, is available from pharmacies. But for emergency contraception, the most effective emergency contraceptive is the copper coil. And that's 10 times more effective than the morning after pill. And that would require fitting at a sexual health clinic or with your GP.
Excellent. Good. And in terms of, obviously, we talked about some of the things that happen in sexual health clinics, Tina, and one of them is also that relationship issues may come about and be transpire there. Not just assault, but just actual problems, sexual dysfunction and so on. How do you deal with things like that? And how do you approach the subject with the general community as well as the BAME community?
Yeah, so this is quite a sensitive subject for people, and it's probably not something that they will divulge very quickly. And quite often they may present with a completely different issue. And when you get to the bottom of that issue, you find out actually it's because they are struggling to have sexual intercourse because they find it extremely painful and that there are relationship issues there. So we have a psychosexual service and it is a fantastic service with trained counsellors in that service, and they work with the person and with the couple as well. So that's certainly a service that we do lean on if across the course of a consultation we do come across someone who we think that might benefit from that. Now, for the psychosexual services, if there is someone that we're examining and we wonder whether they have these issues, it's really important that we rule out anything organic first of all, so to make sure that there's nothing actually wrong that we're missing before we start going down the psychosexual pathway. There's no shame in accessing the psychosexual services. And I think sometimes just the name of the service makes people quite worried and anxious. And in the BAME community as well, I think if we come across as sensitive practitioners and come across as non-judgmental and easy to talk to, that patient will divulge a lot more, and actually you can get to the bottom of the problems faster. Sometimes where practitioners haven't been as sensitive in picking up these issues, you tend to find that patients may attend recurrently with issue after issue, not letting on that there are psychosexual issues lurking in the background. And, you may have them presenting as chronic pelvic pain issues and other things like that. So it's also when you have patients who are recurrently attending, it is worth wondering, is there anything else going on as well?
Okay, thanks. Chitra, we're coming on a final few minutes, so I want to just home in again on sexually transmitted infections. There's often a a stereotype in certain circles that it affects the young, but I want you to also mention about the elderly, because there has been an increase in people of the older generation who get them. And can you tell us as to how that's approached and how we find them, and how do we just make sure that we don't miss anyone who's getting a sexually transmitted infection?
So very good point, Fahim, because you're absolutely right that we often think that STIs are just a thing of young people, and that's not right. STIs can affect any age group, and I can kind of think of several patients in a high age group that we look after or see. And what's unfortunate is that even, somewhere we're at fault, because most of the sexual health messages that we bring out are really addressed to the young population. There are leaflets or pamphlets distributed in universities, and even otherwise, all the advertisement is for young people. And we kind of forget the not just elderly, but also slightly older, middle-aged patients. And it's not unusual that sometimes people start new relationships in their middle age or older age, and they have forgotten all the lessons they might have learned at a younger age of safer sex, of barrier protection. And as health professionals, we have to be aware of it. But, again, not just in sexual health clinics, in GP surgeries, in other places. So just having that kind of index of suspicion of just not so much suspicion, but awareness that sexual health, is something that needs to be addressed in that generation. But also, if people are watching or listening to that program who might fall in that age group, just to, again, I'd like to reiterate that these are services you can access at your GP surgery, but if you feel embarrassed that you don't want to see your family doctor for it, a sexual health clinic is, a place where we look after a whole variety of problems, and it's not a scary place for you to access sexual health services.
Good. And in the last few minutes, Tina, I want to come on to a topic you did want to speak about, and that was postnatal contraception. Obviously, studies say that as a general population level, sexual activity is happening at an earlier age, but relationships are leading to babies at an older age in general. So obviously, you are getting couples who may have been in a long relationship, but then becoming pregnant later on. And obviously, contraception is an issue. And can you tell us about the natural ways of contraception, as well as other things that need to be thought about in this specific subgroup of people, the postnatal group?
Yeah, so postnatal contraception is really important, and historically has been, the provision just nationally has been fairly poor in practically every maternity unit. So we are aware that there's a need. It's become the hot topic now. What is important is that people are aware of the need to start contraception, and the fact that actually from 21 days onwards, it's really important that they do have a contraception method started, just because they can ovulate from day 28. So it's really important that they've started something on day 21 after having a baby. Why it's important is obviously, for women's health and spacing of children. I mean, the World Health Organization does say there should be ideally a 2-year gap between children, but at least here we do say there should be at least a 12-month gap between having children, just for the outcomes, not only for the woman, but for the babies as well, because future pregnancies, there is a risk of preterm birth and small for gestational age babies and low birth weight babies if you don't have adequate spacing. So I'm just going to convert into speaking into a bit of Hindi and Urdu just to explain to people कि बच्चा होने के बाद ये बहुत ज़रूरी है कि आप ये याद रखें कि आपको कुछ गर्भ निरोधक चालू करना चाहिए बेबी के होने के करीब 21 दिन बाद आपको ज़रूर कुछ चालू कर देना चाहिए। उसके लिए आप कॉन्ट्रासेप्शन क्लिनिक आप कांटेक्ट कर सकते हैं, आप हमारे फ़ोन पे फ़ोन कर सकते हैं। हमारा नंबर 0300 1234 154 है। वो पूरा बर्नली, पेंडल, रोजेंडेल, रिबल वैली के लिए है, और जो ब्लैकबर्न में औरतें रहती हैं वो 01254 283 888 पे कांटेक्ट कर सकती हैं। बहुत ज़रूरी है क्योंकि ये आपकी स्वास्थ्य के लिए और आपके आगे बच्चों के स्वास्थ्य के लिए भी बहुत ज़रूरी है। हर औरत के लिए हर तरीका ठीक नहीं रहता है, इसलिए ये ज़रूरी है कि आप अपने या तो डॉक्टर से पता करें या फिर आप सेक्सुअल हेल्थ क्लिनिक से पता करें कि आपके लिए कौन सा तरीका ठीक है। आप अगर अपने प्रेगनेंसी के दौरान ही प्लान कर लें कि आपको क्या तरीका चाहिए, तो फिर आप अपने डॉक्टर्स को बोल सकते हैं। आजकल तो सिजेरियन ऑपरेशन के दौरान भी कॉइल फिट करने लगे हैं, तो ये आपके लिए जानना बहुत ज़रूरी है। Sorry, I'm trying not to go over time for you.
No, absolutely no. It was really good. So thank you for that. Want to bring in Chitra for any last top tips, please. Chitra, in time-honored fashion, we try and do 3 top tips. Can you actually give something for the listeners out there and the viewers, something to take away from tonight?
I think the most important thing I would say is access sexual health services. It's not a scary place. It's, it's somewhere you can get confidential, open access, free service. So use it. Find the nearest sexual health clinic next to you. Use condoms, very, very important, especially if in a new relationship. And also number 3, as Tina mentioned, very important, cervical screening. We know that the uptake is low among our communities, so it's very important that women, once they turn 25, they have regular cervical screening.
Tina, can I get some tips from you as well to sign off tonight?
Yep. So just some top contraceptive tips. It's really important to know that contraception doesn't irreversibly affect your fertility, which is one of the biggest myths in our communities. The other myth is that all contraception causes weight gain. Well, apart from the depot injection, most of the other contraceptives, there's no evidence to say that they cause weight gain, although we do know that women do get a bit hungrier with hormones. And the third thing is that not having a period, so if you're using a contraceptive method which gets rid of your periods, it is not bad for you to not be bleeding.
Excellent. I think we have covered as much as we can in an hour on sexual health. So a big, big thank you to both Tina Dwivedi and Chitra Babu for spending your time on a Tuesday evening and really educating the whole population who are listening and watching, and will continue to do so on our channel. I found it really interesting, and the hour's flown by. So thank you both.
Welcome.
Excellent. And just for those watching, next week we move on to digital health, which is a big issue and a really interesting topic. We have 2 special guests again. We have Dr. Hussein Gandhi, also known as Dr. Gandalf, who many of you will know from egplearning.co.uk. He's also an RCGP Council member, I think, as well. And so he's well involved with this, along with Dr. Aisha Rahim, who perhaps Chitra and Tina, you may have heard of. She works in the Lancashire area as a consultant psychiatrist with a keen interest in digital health. So we'll be going through digital safety, the future of digital medicine, and it should be a really fascinating show. We are out of time, everyone. Thank you again for watching, and I wish you a very good evening. Thank you so much. Thank you.